Good morning. This is the last time you get to have me or have to have me speak, so we'll see if we get to another topic of interest, I hope, for you. I will be followed by Gigi, who will be doing a case presentation, weaving in some of this information into her patient. So this is an overview of recognition and documentation of adult malnutrition. In the United States, and all across the world, there's an issue of malnutrition in hospitalized patients. And we have been struggling with how to recognize and document it in a way that's meaningful. Historically, malnutrition has been identified if somebody's albumin, their blood protein, is depressed. However, the data I will be sharing with you is going to show why that may not be the best marker of true malnutrition, probably a better marker of inflammation. Where did Daniel go? The down isn't working. The enter isn't working. This doesn't work. Help. Okay, I'm sorry. None of the keys move the slides. There he is. We need him, yes. Little AV. No falling. None of the keys nor the clicker moves.
Well, too bad.
Too bad.
Yeah, you're right.
I get to speak. Okay, I will hold these up and see if you can read them.
Well, if that will make it. Yeah?
His computer is frozen.
Okay.
Oh, there it is. There it is. You were magical. Thank you.
No.
Oh, what did you hit?
Not working.
Okay, not work.
So, strange. Let's try with this. No? Yes, no? Okay.
Thank you very much. So today we're going to talk a bit about the Academy of Nutrition and Dietetics and the American Society of Parenteral and Enteral Nutrition have collaborated to look at characteristics for recommending the identification and documentation of adult malnutrition. The American Society of Parenteral and Enteral Nutrition worked with the European Society early on, and so these aren't adopted by Europe at this point, but there was some collaboration to go with them. Also in the United States, diagnosis of malnutrition is a medical diagnosis. And so dietitians' roles in this is identification of these characteristics, documenting that, and then having the physician, with help from our individuals that are experts in putting the right codes together so we get payment, so that we can document that and have coverage for payment in our system. So some contributors of adult malnutrition are primarily deficient intake. Patients in the hospital are either unable or unwilling to eat. And lack of access to food prior to coming into the hospital is often an issue. Increased requirement in certain disease states and pregnancy can lead to malnutrition. Complications of disease, and this should be decreased appetite and not increased. Malabsorption or excessive nutrient losses with their disease. Inflammation. There are positive and negative acute phase reactants. that can cause inflammation and also altered hormone secretion. Aging, we all get a decrease in our sex hormones, testosterone, estrogen, which can contribute to malnutrition, and apoptosis is also a contributor. Inactivity and loss of function. So it can be any of these or all of these above that can be contributors. So on a patient level, their age, apathy or depression, and depression can really impact, particularly in the elderly, their food intake, their disease, the ability to buy or prepare food before they even get into the hospital, their inability to chew and swallow, lack of mobility, lack of some sensory loss. If you don't smell food, or if your tastes have been changed by your disease process, you're not going to eat as well. A big one is often medications. We have patients that have 10, 20 medications that all interact, and many of them, if you look at the first signs and symptoms of most medication, is nausea, vomiting, loss of appetite, and that is to a certain degree individualized by patient, but it is a contributing factor. And then therapies, when we have them on ventilators, when we've made them not able to eat because it is what is thought to be an issue for a long period of time. And then organizationally in hospitals in the United States, there's been a lack of recognition of what true malnutrition is, lack of screening and assessment around this topic, lack of education about malnutrition and identification. Confusion over whose responsibility is it? Is it the nutrition professional / dietitian, or is it the physician? Height and weight often are not measured in our hospitals. They are stated, what the patient says, how high they are and what they weigh. And most of us underestimate or overestimate our height as we age. We think we're still the same height we were at 18. And we underestimate our weight or underestimate our weight also, in that it may be heavier than we think it is, but oftentimes people who've lost weight only don't know they've lost weight, and it could be a wrong weight. We also have a failure to measure and record the food intake. There could be inadequate nutrients provided, lack of feeding assistance by staff when people can't eat, and the nutrition status in our hospitals, and Gigi talked about this, we would have three levels in our hospital of who we would have the most interaction with, because we don't have adequate staff to see everyone. And that low status priority might be someone that would actually have some malnutrition problems. Some of the consequences of not recognizing malnutrition is an increase in the length of time that they're in the hospital. Their wound does not heal, either from surgery or because of a diabetic problem on their foot or an ulceration. Increase morbidity or other complications, and increase mortality or death. Increase muscle and function loss. If you don't have enough substrate, you cannot continue to have good muscle function. Higher infection rate and complications, increased admissions and readmissions to the hospital, and all those lead to increased costs in our health system, both in human, with having to continue to provide care for these patients, and financial. And this is from my colleague in Portland, Oregon, Therese Schollard, who came up with this vision for identification of adult malnutrition. Wouldn't it be amazing to have standardized definitions and characteristics and to know the prevalence of adult malnutrition in our health system, so whatever healthcare facility you work in, the country, or the entire world, that we could all agree on it. It goes back to my discussion about standardized language a couple of days ago, but wouldn't it be nice if we all identified malnutrition the same and could therefore try to combat it? As I mentioned, the American Society of Parenteral Nutrition and the European counterpart have worked collaboratively on part of this, and they came up with an etiology-based malnutrition definition. This decision tree is that, there it is, the nutrition risk is identified, with a compromised intake or loss of body mass. And then the question has to be, is inflammation present, yes or no? And inflammation is measured several ways, but one of the markers might be blood protein like albumin. If no, then if it's been identified, then it's probably starvation-related malnutrition, pure lack of intake of food. If yes, and it's mild or moderate, it may be related to their chronic disease. We know all diseases pretty much puts patients in an inflammatory state. Kidney disease, diabetes, heart disease, etc. And if it's a marked inflammation, lost it again, well, over here, then it may be acute disease or injury-related malnutrition. So a major infection, a burn, trauma, closed head injury. So an attribute of any methodology to identify a condition, and this one is the adult malnutrition, is we want to have basic parameters. We want to have a few hallmarks, a few set of data that we could identify. We don't want it to be 15, 20, because nobody will use it. We want to be able to support the diagnosis with hard data. We want to be able to characterize the severity of malnutrition. And we want to be able to increase or will malnutrition increase or decrease as nutritional status changes. Want it to be as evidence-based when possible. And I will tell you, there's very limited evidence in this area. So this information I'm presenting is consensus-based with people that have worked in the area forever, and we need more evidence. But now that we have these characteristics, I challenge everybody in our country, and perhaps you might want to look at this too, to see if you can validate that these really are identifying, these characteristics are really identifying malnutrition. And these characteristics of adult malnutrition are going to change over time as we get more evidence of validity. But we needed to start somewhere because we were behind the game. So the characteristics that that were come up with these two bodies, and they there is the reference for the article in the Journal of Academy of Nutrition and Dietetics, was just published in May of this year, 2012. It was also published in the Journal of Enteral and Parenteral Nutrition, which may be a little more easily obtained, but PubMed, you could find both of those. And it does not mean that all of these conditions need to be present. The group, in looking at the evidence, decided that any two or more of the above characteristics could lead to the physician deciding to make that diagnosis. So the first, or the one that's near and dear to nutrition, and I should go back, that the plan is for dietitians to document these characteristics. And many of us have implemented that, and our institutions are very happy to have us do that, and then physicians can help document the actual diagnosis. So inadequate intake is less than 50 to 75% of estimated needs. We'll get into why there's that range when we get into the severity of malnutrition. This can be by history. So when a dietitian sees a patient and does a nutritional interview as part of their assessment, and asking the questions about what have you been eating at home, and how has that changed over the last 2 weeks, 6 weeks, couple of months, then you can figure out that that has really decreased by 50%. And oftentimes family members are very helpful. And someone that has a chronic disease, they may not recognize they really have decreased their intake. They've lost 10 kilos, but their family may need to. Or in the hospital, it would be observed. They get food that comes up to them, and they don't eat any of it. And no one is bringing them any food into the hospital, and that was pretty observed. Unintentional weight loss, and there are going to be specific criteria when we get to the tables. And it doesn't matter what their body mass index starts as. We battle not as much as we did a few years ago, with our very overweight population coming into the hospital, and the thought that they can afford to lose a few pounds. It will help with mobility, which it will. But if you weigh 100 kilos and you come in at 90 kilos, that's 10 kilos, 22 pounds over a short period of time. Something is going on, and that needs to be identified. Not that they're still very heavy and above their recommended weight if there's a height like mine, but it still can be an indicator of malnutrition. And then we are, as dietitians, doing physical exams, looking at muscle loss. So either doing official tricep skin folds or just using your fingers on arms, looking at intercostal muscles, doing a physical exam, looking at subcutaneous fat loss, looking around eyes to see if they're sunken, looking at fluid accumulation, because often that can be indicative of protein issues in their ankles, generalized edema. And then functional status is the one that we have not adapted probably wholeheartedly across the United States. It's a grip strength. They do have dynamometers, and it's a hard word for me to say, that you can do a objective grip strength that gives you a number. But in fact, and this is what our physical therapists use, and maybe this is what is used here, have somebody grip your fingers and see how hard they grip, and ask if there's a family member or if the patient seems like they have lost grip, can't open a jar of something, and they used to be able to. So there's ways to do it without the fancy tools. So why is not serum albumin a great marker for malnutrition? As I indicated earlier, in inflammatory disease, illness, and injury, that elicits a cytokine-mediated acute phase response, alters hormone secretions, and it favors a catabolic state that results in metabolic alterations. So over the short run, the acute phase metabolic response is likely an appropriate and adaptive response. It's very helpful in our bodies. If the underlying stressor is severe or goes on for a long time, then you can have an adverse outcome. And inflammation can blunt favorable responses to nutrition intervention. So we may be providing what based on calculations, the appropriate nutrition intervention, and the patient isn't improving their nutritional status, and that inflammation may be the exact cause. And nutrition alone is ineffective in preventing muscle loss when there's significant inflammation. So that acute phase metabolic response, there's an elevated of resting energy expenditure, an export of amino acids from the muscle to liver, because they're going to use that for energy, an increase in gluconeogenesis, an expansion of the extracellular fluid, and that's why looking at that fluid status is important, and a shift towards production of positive acute phase reactants like CRP. And I'm not sure if you're measuring CRP here, but we often get it measured in our institution. The body downregulates albumin synthesis so that urgently needed proteins for immune, clotting, and wound healing functions can be made. And that's why albumin is often depressed in these patients. Albumin over time in a healthy population, all things being equal, can show you some nutritional status. But in our hospitalized patients, it probably is an artifact of the downregulation of it, making it. The positive is that antibodies, complement, and C-reactive protein and fibrinogen are therefore made, which you need in that acute phase. The negative is that albumin, transferrin, prealbumin, retinol binding proteins all decrease. So these cytokines promote muscle catabolism. They inhibit protein synthesis and muscle repair, and they trigger apoptosis, which is programmed cell death, and they influence contractility and function. And as I said, nutrition alone can't make that difference. We will get sometimes orders for nutrition intervention for someone that's going to go to surgery next week, asking us to please improve the patient's albumin. Well, that's pretty impossible in 7 days. The half-life of albumin is what? Anybody remember? 21 days? So it's not going to go an iota up in a week. So, but they recognize, the surgeons recognize that there is some decrease in outcome if albumins are low. And we're going to go over that. I skip that. They have the slides. So we've got enough inflammation. So the characteristic to diagnose malnutrition, as we talked about before, are decreased food and nutrient intake, unintentional weight loss, loss of muscle, fat, fluid accumulation, and hand grip. So we have put together, along with, this is both the Academy and ASPEN, some parameters based on if it's an acute, well, I can't. So the acute illness or injury has some specifics of what percentage of weight loss should be, chronic illness, and social and environmental. They just don't have access to food, which that means. And those, if any two of those meet parameters, then we can chart that they meet the characteristics of adult malnutrition. Oh, I put two of them in. Excuse me. This is Dr. Butterworth, who in 1974 had an article in the Journal of American Medical Association. Oh, no, it was in Nutrition Today, but it also went to JAMA. It said, "The skeleton in the hospital closet." And he said, "I suspect that one of the largest pockets of unrecognized malnutrition in America exists not in the rural slums or the urban ghettos, but in the private rooms and wards of our big city hospitals." There was a revisit of this issue in the early 2000s, and it really hadn't changed much. Much of the malnutrition we see is iatrogenic. Literally, usually means physician-induced, but the care team induced. What happens to patients when they're in the hospital? We make them NPO. We don't let them eat. We may give them clear liquids, those lovely juices a little bit, because we're doing all these tests. We take them in and out of surgery, and the food that they have available in the hospital may not be to their liking or their cultural needs. We've done a great deal in the United States in trying to change that and actually have a system called room service in many of the hospitals, where the patients can call or order the specific foods they want to eat when they want to eat them. Well, hope to gather some data to see if that improves. So we really need to pull all of the reasons together why patients can be malnourished in our hospitals. And it really does take teamwork. It takes physicians, dietitians, nurses, and chefs, or the cooks, to help us out with this, as well as pharmacists. Physiotherapists, too, should be up there. Maybe occupational therapists, too, which we have in the States. So you may have a clinical presentation of malnutrition and want to change that. They have an altered metabolic status, and the treatment specifics to predisposing factors such as starvation, chronic disease, or acute illness. So the patient comes in with maybe one or all three of those, and then our treatments make it worse. So to bridge that, we did some work with, I said, the Academy did work with the American Society of Parenteral and Enteral Nutrition, and have decided that those factors that I identified are reasonable and reliable based on the literature and research at the time of the establishment of the criteria, and we will change them with further clinical understanding. And they're not meant to the quote-unquote be-all, end-all for adult malnutrition. It is a place to start. But it's more validated than looking at albumin and assuming somebody that just had surgery and they came in healthy because their albumin dropped to lower levels is now malnourished. Doesn't make any sense. These criteria will really truly identify who's malnourished. And then we are still in the United States using ICD-9. Those are the codes for diagnosis. Everybody else in the world are ICD-10. We're supposed to go live with this in October of 2014. 13. I've heard some rumors that it may be later than that, and our big challenge is our electronic healthcare system. And the ICD classification is a system to categorize and communicate adult malnutrition, and it allows for benchmarking of prevalence. So what we've done in our institution is I got a baseline of what codes, those malnutrition codes that we have, 260 and 263 I think they are, before we implemented this program, and then I'm going to look 6 months later to see if it's made any difference. So the benefits of early identification and treatment of malnutrition is to improve patient outcomes. That's what we're all in the business to do here, right? We want people to be better. We want to reduce the complications. Infections in patients is a big deal and increase healthcare costs, and it decreases their ability to be healthy. Reduce length of stay for malnourished patients, so try to get them home and out of the hospital environment. Decrease hospitalization expenses. Obtain appropriate reimbursement for care provided. So based on whatever diagnoses are sent to our insurance companies at time of discharge, they pay the hospital. And this would be a diagnosis. If it's appropriate, that there might be some additional payment. Improve the assessment of severity, which is the case mix index. Thus increasing allowance of overall length of stay. So if someone is more ill in the hospital, the insurance company will give you extra time that they will pay you for them to stay in the hospital. So if you identify this severity, the malnutrition, they're going to say, that justifies that they're in the hospital a little bit longer, therefore we'll pay for that extra day. If not, then the organization, the hospital, would still have the patient in the hospital because they need to be, but didn't get paid for a day or two because the insurance company goes, everybody who has a cholecystectomy should leave this time or something. And improve the accuracy of risk and mortality classification. So with that, I will give you Gigi, who will put this into practice. Thank you.